Welcome everybody to today's Fuse research seminar, which is on the impact of social prescribing on health and well-being. Next slide, please. As many of you will know, Fuse is the Centre of Excellence in Public Health Research across the Northeast universities, and we work in partnership with policymakers and practitioners, and we're also a member of School for Public Health Research. We'd encourage you to tweet about the event with the hashtag FuseRPM. Next slide, please. Just a few house rules around engagement. While we have the first set of presentations, if you could ensure that you're muted and that your camera's off. And then when we come on to the panel session later, then questions can be placed in the chat. We're really excited to be able to chair this event today and to talk about the impact of social prescribing in the Northeast. Unfortunately, Professor Suzanne Moffat, who would normally be presenting as part of this, as the lead of this NIHR funded grant that's being presented, has had a family bereavement, so she's unable to join us today. But kindly, Nikki O'Brien, who's Associate Professor of Health Psychology at Northumbria University and is a co-investigator on this grant, has kindly agreed to step in and present the introductory slides setting out the project context. So Nikki, thank you very much for joining, and I'll hand over to you now for the introduction.
Thank you, Claire. So hi, good afternoon, everyone. As we said here, just a little brief overview to the context of this afternoon in terms of, first of all, what is social prescribing? And social prescribing broadly is seen to be a framework, a way of linking patients with sources of support within the community. And that's usually, but not exclusively, through primary care or linking individuals from primary care, with the general purpose being to improve their health and well-being. So it's allowing patients, accessing patients to non-clinical sources of support and linking them into different health voluntary community sectors and health and local government services. So to enable this, the frontline health staff, those who are primarily but not always in primary care, as I say, will refer patients to a link worker. That patient will be connected to that link worker where they will work with them to identify any problems and then to set some goals that might be used together to come up with and co-produce a social prescription relevant for that individual. It's really important to be aware that it's more than just signposting, and it's actually explicitly recognising that some people will need support to access services over and above just being directed to that service. In terms of the policy and the evidence background for social prescribing, it's not necessarily new. In 2006, the Department of Health introduced social prescribing for people with long-term conditions. And since then, there have been many social prescribing initiatives, but they're different, and they differ in many different ways in terms of the funding model, the scale of them, the target populations. So it's been quite tricky to compare the different types of social prescribing available. The systematic review in 2017 by Bickerdike attempted to synthesize the evidence for social prescribing and concluded that actually the research that was available failed to be providing any sufficient evidence for success in improving either outcomes for individuals and value for money. And then in addition to that, the PHE evidence synthesis in 2019 similarly concluded that there wasn't effectiveness, no evidence for effectiveness that was robust enough to actually conclusively state about the effect of social prescribing. Having said that, there is still obviously a drive for social prescribing and a big interest for it, and it's a key part of the personalised care agenda. And this is where within the NHS long-term plans, social prescribing link workers are being employed within primary care networks to deliver this role. By the end of 2024, it's expected that there will be over 1,000 trained social prescribing link workers in place. And of that, there will be 900,000 people referred. You can see from the quote here about what the NHS long-term plan says about social prescribing in terms of its building of community resilience, personal resilience, and reducing health inequalities. So there are considerable claims being made about the potential and the value for social prescribing, but actually in terms of kind of whether it can and how it can address the wider determinants of health, it's still to really be determined. So the intervention that we're going to be talking to you about today is Ways to Wellness Social Prescribing. And this was developed over an 8-year period and co-produced with people with long-term conditions. So it began in 2015, initially for 7 years. And over that time, it had the target total eligible patient population was just over 14,000 people. Over 7,700 referrals were made, and of that, over 5,800 people have actually engaged with the service. The overarching aim of Ways to Wellness is to improve the health-related outcomes and quality of life for people with long-term conditions, and to reduce costs and/or improve value to the NHS. So I'm briefly just going to mention a bit more about Ways to Wellness, how it fits and what type of social prescribing model it follows. So it's funded primarily through the Clinical Commissioning Group, and then it has additional top-up funding from the Cabinet Office, from the Big Lottery Fund, and the Social Investor. The funding model that it has is a social impact bond, which is a contract with the public sector or the governing authority, where the organisations who deliver those outcome contracts and make funding for services conditional on achieving results. Ways to Wellness then sits as a special purpose vehicle, and by that it's carrying the financial risk and holds the contracts with the provider organisations that deliver the intervention. And the intervention here, Ways to Wellness, is delivered by 2 not-for-profit organisations, and the outcome payments are based on improved long-term condition self-management and reduced secondary healthcare costs. However, it's important to note here that the payments to the service providers aren't tied to those outcomes, but they're actually tied to the number of clients that they support. And I'll touch on that again in a second. So the referral criteria for people eligible to receive Ways to Wellness social prescribing, these are the criteria. So they're registered within their GP practice in the area in which it was available, aged between 40 and 74, with one or more of the long-term conditions listed, COPD, asthma, diabetes, etc. And there were additional further referral criteria being social isolation, anxiety and depression, obese or inactive. So that's the range of different sort of criteria that people would be eligible to receive the intervention or to be referred for the intervention. In terms of the outcomes of Ways to Wellness social prescribing, they use the Wellbeing Star, which is a self-assessment tool. And this is a Wellbeing Star which is used both at baseline with people on at the point of referral and then every 6 months thereafter. And it's a self-assessment tool where the link worker and the individual would work together and think about the 8 different domains of lifestyle, self-care, symptom management, work volunteering, activity, money, home environment, personal relationships, and positive feeling. And the individual is asked to scale on from 1 to 5 on each of those domains. And it helps them to work together to identify problems that the individual has, and also then co-produce a personalised action plan. So to identify the areas in which they really would like the most support and would like to see the most improvement. Payments to the individuals are based on completion of the Wellbeing Star. So as I said, it's not linked to outcomes per se, but it is linked to completion of the Wellbeing Star as a measure of continued engagement, the individual remaining with the intervention. So how the actual model might look here just shows you that the eligible patient will come in. We will primarily refer from primary care to a link worker, and that link worker works with the individual to identify their needs and identify the areas of support for onward referral to other services within the VCSE sector. So who's the area, where is the area served by Ways to Wellness? So it covers 16 general practices across 10 electoral wards in West Newcastle, which has a population just over 100,000. Within those 10 wards in that locality, 5 of those are in the highest quintile of deprivation. And specifically, over half of those 10 wards have higher than average levels in England for limiting lifelong long-term conditions and disability, long-term employment, social renting, deprivation, and ethnicity. So the intervention is delivered to both white and Black and minority ethnic groups with very high levels of socioeconomic deprivation, long-term unemployment, and high levels of limiting long-term health problems and disability. So the study that we're going to be talking to you about today is the social prescribing in the Northeast study, the Spring Northeast study, which was funded by the National Institute of Health Research Public Health Research Programme. And the aim of the intervention, the aim of the study was to evaluate the impact and cost of a link worker social prescribing intervention on health and healthcare costs and healthcare utilisation, and also to observe link worker delivery and public engagement, patient engagement. The study design is multi-method study design. And the target group, as I said before, the eligibility criteria for the Ways to Wellness intervention was people with one or more long-term condition of the list that I presented. The target group for this study was people with type 2 diabetes. And some of those will be people with type 2 diabetes and or another or multiple long-term conditions. But for this study specifically, every individual also had type 2 diabetes, with an exception of one of the studies you'll hear about later, which was the COVID study. The multi-method design for this was both quantitative and qualitative. The primary outcome for the quantitative component was HbA1c, and we also had quantitative measures of blood pressure, cholesterol, BMI, and smoking. Finally, measures of healthcare costs and cost effectiveness. For the qualitative component of the study, there's both a link worker ethnography and a service user ethnography, and then also an interview study examining the impact of COVID-19, which was responsive to the pandemic at the time. Thought it would be useful to briefly mention the health of the population. So we've talked about the deprivation, the socioeconomic level of the target population. In terms of the health of the population of those who could be referred for the intervention, we do have a subset of sample of people where we had data from EQ5D, which is the health-related quality of life data. So this was data from 694 individuals who were referred to the intervention. These were referred to the intervention for having any of the eligible long-term conditions, not just those with type 2 diabetes, which is what the majority of the data you'll hear about this afternoon will be about. For those who aren't familiar with the EQ5D, it's self-assessed, self-reported health-related quality of life, which comprises a descriptive system where the individual is asked to rate their levels of mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And they scale that from 1 to 5. From that, there's a weighted system which allows you to compute health state value for each individual, which uses those 5 domains and gives you a weighted value based on sort of country-specific population preferences. And a higher health state value represents better health. In addition to that descriptive system and the health state value, there's the visual analog scale, where an individual simply reports their current health from 0 to 100, worst to best health. So what I can show on this slide here is you can see briefly how the intervention population compares to the UK and age similar population in terms of their self-reported health. So on the left graph, you have the health state value. So this is the weighted measure of those different 5 health domains. And on the right, you can see the visual analog scale. So these 2 graphs are clearly showing you that the intervention population have much worse, substantially worse health than their counterparts within the UK and the same age population. In addition to that, you can see from those specific domains that each of those domains of mobility, self-care, usual activities, pain and discomfort, and anxiety and depression there's a high proportion of people within that intervention group reporting experiencing some of those problems. So to just reiterate, these data clearly show that there's a poor health of the intervention sample. And what we're going to go on to talk to you about is people more generally, and specifically focusing on those who with type 2 diabetes. So thank you, and I'll hand over.
Thanks so much, Nikki, for that really clear introduction. It's not always easy to speak to a colleague's slides, but you did an absolutely fantastic job. Now we're going to have a series of presentations looking at the findings of the project. Nikki has given us the kind of background, the context and the aims of the work. And we're going to start with Professor John Wildman, who's Professor of Health Economics at Newcastle University, and he led the quantitative analysis looking at both the impact and also the costs and values of the intervention. So over to you, John.
Thanks, Claire. So I'd just like to start off by thanking the people who worked on this work package alongside me. So Joe Wildman, who's here at the presentation today, but also Wael Mohammed and Owen Maloney, who subsequently left the university and weren't able to make it. So what I'm going to do is I'm going to talk about this outcomes worth, the cost effectiveness, but I'm also going to try to sort of just raise some issues around the concept of valuing social prescribing. And I'd like you to sort of keep that in mind as we go through. So there's a brief outline of what I'm going to talk about. I'm going to say what is value, what impact does the intervention have on our measured outcomes, and what are the implications for cost effectiveness. So when we think of value, we talk about it as economists, we think about it in terms of either gross or net. And if we're thinking about things in terms of efficiency, we need to think about net value. So net value is the benefits net the costs. Now that sounds like a really quite straightforward concept. It's crucial for economic evaluation. What's the benefit net the cost of any intervention? And it's crucial obviously for aiding decision makers. But of course, it does raise two fundamental questions here. The first one is, what are the costs? So always think about these in terms of the opportunity costs. So where the money could be spent elsewhere, so the next best alternative. And that sort of often thinks about the next best alternative in terms of what type of benefit we could get from that spending. So what are these benefits? Are we talking about all the potential benefits, or are we simply talking about health benefits? So often when we think about cost effectiveness, and we think about cost effectiveness within the NHS and from a health decision maker, from a health service perspective, we're thinking about health benefits alone, not necessarily all benefits, which may be something that economists would want to take into account. So I sort of ask you to bear that in mind as I sort of go through this, and I'll return to it at the end of this brief presentation. So the objectives, always just to remind you, is to look at the impact of the intervention on the primary health outcome, which is HbA1c, a measure of blood glucose control. We then got a series of secondary measures, blood pressure, both systolic and diastolic. I've also looked at it just in terms of people who have high blood pressure. We have cholesterol, but that's only total cholesterol, so we don't have it split. BMI and smoking status. We also have information on healthcare costs and use, inpatient, so these are inpatient elective and non-elective care, outpatient care, and accident and emergency. I'll talk a little bit about that data in a moment. So we use all that to look at the impact of the intervention on those. Then we sort of build all this together to try to look at something around the cost effectiveness of the analysis. So is the intervention, or is the waste to wellness social prescribing a cost effective method of reducing HbA1c and blood pressure? So for this, we have three sources of data. We've got the quality outcomes framework data for eligible patients registered in treatment and control practices. So as Nikki presented in the introduction, the Ways to Wellness was introduced geographically in the West End of Newcastle and wasn't in the East End of Newcastle. So this provided us with a treatment area, the West End, and those treatment practices, and a control area, the East End. So from those GP practices, we obtained their quality outcomes framework data for eligible patients, where eligible patients are those who are eligible for Ways to Wellness for the social prescribing intervention. So that's aged 40 to 74 with one of the range of conditions for eligibility, as Nikki outlined earlier. But all of these individuals have type 2 diabetes. So to qualify for this, you have to have type 2 diabetes. If you don't have type 2 diabetes, we won't see you in our data set. For the QOF, we have data from the 1st of April 2011 up to the end of March 2019. It was the intention to go into 2020, but COVID put an end to that. And we have measures on age, sex, ethnicity, presence of additional intervention eligible comorbidities, and information on individuals' index of multiple deprivation. So the index of multiple deprivation of the area in which they live. We could then link this data to data from Ways to Wellness. So that identifies which of those individuals in those GP practices have received the intervention. And then we can also link all this through NHS numbers to secondary use services. So this is the secondary use services data, gives us the information on whether individuals have used secondary care and whether they have and whether they've used secondary care and how much that secondary care cost, and whether that secondary care was inpatient, elective, non-elective, outpatient, or accident and emergency. And we use the final tariff, so the national tariff for the costs of services, so that we can keep costs comparable across the nation, rather than local tariffs or regional tariffs, which may have other sort of market forces factors built into them. All of our data is extracted by the North of England Commissioning Support Unit next, so I have to be thankful to them, especially Bob Gaffney, who provided a lot of help and support in understanding this data set. So depending exactly on what we estimate, we've got about 50,000 observations, we've got about 8,300 individuals, 4,800 of those individuals are in treatment practices, and about 1,400 individuals actually receive treatment. Now, we use a difference in difference analysis. So just while we were going through the introductory slides there, it was announced that the Nobel Prize has been won by David Card, Joshua Angrist, and Guido Imbens, who have actually been developing in economics these difference in difference models, which is what we end up using to analyze this. So cutting edge, I fear. What we can do is we can, again, exploiting this fact that we know that the treatment is introduced in the West End of Newcastle in April 2015. It's not introduced into the East End of Newcastle, so we can use the East End of Newcastle as our control group, the West End as the treatment group. We follow them over time, and then we can see what happens as we switch the West End from untreated to treated. So pre-2015, April 2015, post-April 2015. I'm going to present everything here really as intention to treat. That was most of the work that we did. So intention to treat means that if you are present in a treated practice, you are considered to have been treated. So this means you may not have actually received the treatment. Now, this is generally considered to be the best way to undertake these types of analyses. And this is often to do with the fact that it reflects the real world nature of treatment. Treatment is available, but you don't necessarily receive it. It also helps us to overcome problems around regression to the mean. So if the people who are the most ill are the first to receive the treatment, then it may be the case that just by the passage of time, nothing to do with the treatment, their health improves. So that regression to the mean problem. What it does mean, however, is that everything here is probably going to be a conservative estimate. So any estimate of effect is probably going to be larger than that which I display. Now, instead of having big tables of numbers, what I tried to do was just put this in a graphical format. So what I'd like you to do is just look at that top left-hand graph. So this is the results from the intention to treat for the HbA1c, our primary outcome. What we have on the x-axis is the year, so it's the passing of time. And on the y-axis, what we have is the measured difference between the treatment group and the control group. So if you can see this first dot here, what this is saying is that in 2011, on average, the treatment group had a higher HbA1c than the control group. Now, what we would hope to see if the intervention, if Ways to Wellness is having an effect, what we would hope to see is that these dots that I'm highlighting here are either on this horizontal red line or above this horizontal red line. And these vertical lines, blue vertical lines, they are there to demonstrate confidence intervals. So how sure are we about the result? Now, if the intervention is effective, what we would expect to see, as I say, those dots will be on the red line, the horizontal red line, or maybe above it. Then once we hit the date of treatment, which is shown by the big vertical red line, we would hope that those dots fall below. And that is exactly the pattern that we see with HbA1c, that over time, the relative to the control group, the treatment group HbA1c is improving. And what we can see is that as the length of time that treatment is available for, that improvement is increasing. So it's getting bigger over time. And so I think that's a really exciting result for our primary outcome. If we look across our other measures, we can see that there's some evidence of this going on for blood pressure, that by the time we're getting to 2017, 2018, we're getting an effect, a negative effect. The dots are below the red horizontal line, but nothing is really statistically significant here. Now, that could reflect a number of things, including the intention to treat that's ongoing, the issue that I was talking about. It also about the number of people we have in our study. Although it's large, it may not be sufficiently large enough to identify statistically significant events. I'm going to focus mostly on the HbA1c and the blood pressure because there's some measurement issues around the other health outcomes that we have. So cholesterol, ideally you'd split it between the high level and the high density and low density cholesterol, but we don't have that. We only have total cholesterol. BMI in the QOF is not necessarily well recorded, neither is smoking status. So HbA1c and blood pressure are very much part of the payment mechanism for GPs. So these generally are very, very well recorded. The other health outcomes, less so. So in summary, the intervention had a statistically significant effect on HbA1c, although maybe not clinically significant. The impact was increasing over time. We also found that the HbA1c effect was larger for individuals in the most deprived areas with fewer than 2 additional comorbidities, for those who are older and those who are ethnically white. For blood pressure, there was no overall statistically significant reduction. However, there was a significant 5.6% reduction in the probability of having high blood pressure for the ethnically non-white, and a significant 3.5% reduction for the younger age groups. For the other outcomes, there were no estimated effects. If we move away from the intention to treat, we do find actually some really quite large, statistically significant and clinically significant reductions in HbA1c. So this is when we look at the people who actually received the treatment. Now, as I was saying before, that there may be here risks of bias from regression to the mean. So it may be the case that our actual estimate lies somewhere between the -1 that we're finding in the intention to treat analysis and the -4, maybe as high as -8, but somewhere between that in this non-intention to treat analysis. For high blood pressure, we find reductions as high as about 10%. So reduction in the probability of having high blood pressure of 10%, but the results do depend on the exact specification of the model. For the cost outcomes, again, what we'd like to see is that same pattern. So a gradient going down from left to right as we cross the vertical red line. But we don't see that so much with the cost data. And again, we don't seem to be detecting particularly statistically significant results in our intention to treat analysis. Again, if we start to think about things a bit more generally, so attention to treat analysis, small reductions in expected costs, some larger reductions for some groups. So for those people with no additional comorbidity, we're seeing reductions in the region of about £50 per person per year for non-elective inpatients. But again, when we move away from the intention to treat analysis and we're looking at individuals who receive treatment, we are finding reductions of somewhere up to, or in the region of £60 per person per year for non-elective care. And that's an 18% reduction compared to the control group. But again, it's not statistically significant. And again, this may be to do with the numbers of people who we observe. Because even in what is quite a low health population, as Nikki demonstrated, with the EQ5D, healthcare is still quite an unusual event to be used. We do find also some evidence that individuals are moving away from accident and emergency and non-elective care to elective care and outpatient care. So that may be a factor sort of representing or indicating that individuals are having better planning around their healthcare use. So the second part of this is the intervention a cost-effective way of reducing HbA1c and blood pressure? So cost-effectiveness analysis focuses on the very narrow benefit of reducing HbA1c and blood pressure. Now, important, but these are the ones that we've really only got reliable measures for. We apply this to a well-known type 2 diabetes simulation model of for the UK. This is very well validated from Oxford. And what we do is we look to see whether the impact of the intervention then is individuals go through time and the potential costs and benefits, does it end up to be cost effective? So the model will analyze a whole range of outcomes, many of which we have no data for. So we had to use population averages. So we didn't have information on ischemic heart disease, myocardial infarction, stroke, etc. Also for risk factors, as I said already, we didn't have the separate high density and low density cholesterol. We didn't have white blood cell count. You know, there are lots of information that we didn't have because it wasn't a clinical trial. We were relying on the secondary data from QOF and stuff. So we took a healthcare provider's perspective. We simulate future quality adjusted life years and potential costs, where we take the costs of the intervention from waste to wellness themselves. And we find that it's not a cost-effective way of reducing HbA1c and blood pressure. And this really is of no surprise to me. You know, this isn't an intervention aimed at reducing HbA1c and blood pressure. It's an intervention that's aimed at a real heterogeneity of outcomes. And that's really then what I'm going to return to, to talking about. Before I get to that, just to say as a summary, it's a complex set of results which mirror a complex intervention. But there's some really important takeaway points. Firstly, that the intervention had a measurable, if small, impact on health outcomes such as HbA1c, and that's very promising and potentially exciting. This is not an intervention targeted at those outcomes, but it still seems to be having some effect. Hospital use and cost outcomes are at times economically, if not statistically significant. So that 18% reduction, for example, I talked about earlier. But as I say, hospital care is still a relatively rare event. And as a decision maker, you would be reluctant to recommend the intervention as a cost-effective way to reduce HbA1c and blood pressure, but that doesn't necessarily mean we shouldn't recommend the intervention, ways to wellness, or social prescribing more generally. And the reason for that goes back to this concept of value. So if social prescribing is aimed at the social determinants of health, cost-effectiveness analysis may not be the appropriate way of thinking about it. It may be much better to think about the cost-benefit analysis, where we can think about all of the potential benefits, so from a societal view, that may arise from social prescribing and ways to wellness interventions. I mean, this is a table that Joe and I had published in Value in Healthcare right at the beginning of the project. saying there's so many different perspectives that we should perhaps be taking here. And then there's so many different outcomes that could be of importance here. So they could be for individuals, things like improved relationships, improved well-being, improved self-esteem, as well as those cost effects issues that the healthcare service are concerned about, reduced healthcare use, different healthcare use. So social care use versus healthcare, these are so many things that we would need to think about as outcomes. Also, it raises all these issues that we still haven't really, still trying to get a grip with. Who is the unit of treatment? Is it the individual, the GP practice, the community? Whose perspective should we take? The community, the society, the healthcare planner, and what are the appropriate outcomes if we really, really want to measure value? And that's the end. Thank you.
Oh, thanks very much, John, for a really nuanced and comprehensive overview there. And just to remind participants that we'll have a chance for questions in the discussion section at the end. So if you have any questions for any of the presentations, please hold them until we go into the discussion after the break. So there's John's been talking about the quantitative side of things, showing some of the complexities in the evaluation there, and perhaps more of that will come out now as we've got a series of three shorter presentations looking at the qualitative work package, looking at experiences of link workers and client service users in the intervention. And so we've got Dr. Bethan Griffith, who's a researcher and is a GP, and she's doing a PhD on social prescribing at Newcastle and was involved as a researcher in the project. We've also got Dr. Kate Gibson, who was a researcher leading the client ethnographies, and also Professor Tessa Pollard, who's a co-investigator and led the work package based at Durham University. So I'll just hand over to Bethan to start us off in this section. Thank you, Bethan.
Thank you. I hope everybody can see the presentation. Thank you, Claire. So everybody can see that. So my name is Bethan Griffiths, and as Claire said, I'm going to talk to you about the link worker ethnography. I'm going to start with a little bit of background about link working before giving a little bit more detail about the link worker ethnography and our findings before finishing with some key take-home messages. So what do we know about link working? I'll start with that. We know that link working type roles have very varied aims and objectives, ranging from behaviour change to addressing inequality. And perhaps unsurprisingly, it's also becoming very clear that the nature of link working delivered through different social prescribing interventions is also very varied. This has previously been described as being on a spectrum between a light touch to a more holistic approach, and more recently between something more transactional and something more relational. We also know that link work is essential to the complex network of relationships that make up social prescribing. So what were we aiming to do in this particular ethnography? Well, we really wanted to engage with the complexity of link working and understand the lived experience of the link workers delivering the intervention, and to explore how link working was becoming embedded and shaped within local context. So my colleague Jane Jeffries, who initially started the ethnography, subsequently went on maternity leave. She spent close to 12 months with link workers at the provider organisations who are delivering the intervention. She spent time in their offices, as well as shadowing the link workers when they were seeing clients and working in the GP surgeries. She also undertook individual interviews as well as focus groups with the link workers. Jane recorded extensive ethnographic field notes, which when I took over from her, I then analysed along with the interview and focus group transcripts, aiming to draw out and distill themes from the data. So what did we find? Well, I wanted to start by considering what we learned about link working practices. There was some variation observed between individual link workers in how they approached the role. For example, if we start with the example of Hillary, she drew heavily on her biomedical background to encourage behavior change, focusing on self-management, really on personal responsibility. She said, what I want to get out of this is the courage to actually look after their own conditions. She went on to say, everyone has got to start taking control of their conditions. This contrasted with the approach of Abby. Abby was observed dropping in unannounced on a client who had an upcoming meeting about her benefits. She has brought a number of documents to support her case. At her meeting, she takes 4 letters from her bag. The first shows the smoking cessation course the client attended. The second and third are 2 letters written by Abby using the client's case notes. The fourth is a letter from Welfare Rights showing the impact that her health has had on her finances and debt management. Abby wanted to bring them to ensure that she received them and so she could check in on how the client was feeling before her meeting. So really here, Abby is offering really quite an intensive level of support with both sort of practical and emotional benefits. And just thinking back to the slide that John presented there on value, we can see a range of potential benefits for Abby's clients in this approach. But the nature of link working practices was shaped by so much more than individual link workers. You might recall from the introduction that primary care really were expected to refer new clients into the intervention, but it became clear that there was differentiated buy-in from primary care locally, so referral rates could be very variable between GP practices. The issue of GP engagement was raised in one link worker team meeting where strategies were discussed to develop working relationships and to understand the role of different actors within social prescribing, breaking down barriers. But one link worker said that she felt uncomfortable doing this, and it was clear that there were different relations of power. And although it was acknowledged that primary care teams might have the same kind of nerves and don't feel comfortable, overall, the lack of primary care engagement was a source of frustration for many of the link workers. It's like they A, don't value the service, B, are not really aware what we do, and C, seem incapable of making referrals. Although Molly, one of the other link workers, was slightly more optimistic in the focus group that we will fit in and we will be valued for what we're doing. An important consequence of this was that link workers were increasingly required to generate referrals themselves. This could mean cold calling eligible clients in a process that could be very time consuming and quite convoluted. If we take the example of Sam, he spent all his time at the GP surgeries securing new referrals. Sam must submit a request to a GP seeking permission, consent to offer the intervention to a patient. He can call the patient to provide them with the information regarding the service, but he cannot book a new client in for an appointment until he receives this permission. So Sam rang potential clients. If they accepted the intervention, he had to get a GP to sign a paper referral form before he could book them in. This took time and diverted Sam from face-to-face contacts with existing clients. Referral numbers were important within the intervention. As we heard, the number of beneficiaries was linked to payment. And these sorts of organizational structures were another important factor in shaping the link worker routines. So Charlie was an experienced link worker who felt that generating new referrals was a good thing, good for the people, good for the community. And the more referrals we can have, the more change we can effect. Although Charlie did also acknowledge that it was difficult to bring in the dirty business of money and staying afloat organisationally and finding a way to make that part of the culture. But for Charlie, these tensions were well managed within the intervention. However, not all link workers shared Charlie's feelings on this. We saw earlier the example of Abby, who was intensively supporting one of her clients. And in the focus group, she went on to say, I thought when I applied for the job, I'd be doing a lot more supporting than what we're encouraged to do. So my impression is that we're kind of told to shy away from that as much as possible because we've got so many targets for referrals and assessments. She went on to describe how she'd wanted to set up a support group, a positive psychology group for her clients, but had been unable to do so because she got told to focus on targets, showing how organizational structures could really shape the scope and nature of link working. Increasing referrals also meant higher caseloads, averaging during the ethnography around 100, which would be interesting to compare with the proposed caseloads for the new NHS link workers. There was a definite sense that link workers didn't feel they always had enough time to offer the intensive support they would have liked. Other examples in the data also suggest that more contacts were being made over the telephone rather than face-to-face. And it was likely that some of these frustrations contributed to quite a high turnover of link workers during the ethnography, although we did also observe many link workers leaving to take up NHS primary care network social prescribing positions. In terms of helping clients to achieve the goals they had set, we observed onward referral to a number of third sector organisations. Commonly, these were related to lifestyle changes such as diet and exercise, although welfare advice and housing organisations are also fairly common. And there was a sense that local area inequality and lack of local investment was another factor that could shape and limit the scope of link working and onward referral. Lucia felt the area was less well resourced than other areas, which was difficult for clients who could not travel. There's nothing in the local area. And if you are someone who struggles with anxiety and you can't go too far from home, seeing these structural challenges was frustrating for link workers like Amy, who was frustrated really at why our clients are in the position that they're in. One link worker cited a local council document that likened the rollout of social prescribing without adequate funding for the local voluntary and community sector as having lots of travel agents and no holidays. So what were the key messages? Well, in summary, there was differentiation in link working practices between the individual link workers. But really, link working was shaped by a number of factors beyond the control of individuals, differential buy-in from primary care, organizational structures, increasing caseloads and restrictions in terms of local area provision and inequality could really shape and determine the scope of link working. Over time, it did appear that link workers were less well positioned to deliver the type of client-led intensive support that many of them wanted to be delivering. This fits well with current understandings of link working. We saw how individual, interpersonal, organizational and policy contexts were all important in shaping the nature of link working within this intervention, sometimes in fairly unanticipated ways. Overall, the nature of link working that emerged was not static. It was an evolving balance of all of these contextual factors. And the findings really highlight the importance of considering the impact of all of these factors when making claims about link working, really to ensure that the lived experience doesn't diverge from wider narratives of social prescribing. Thank you very much for listening. And I'm now going to hand over to Kate Gibson, who will talk to you about client experiences.
Hi, everyone. Thanks very much, Bethan. So I'm Kate and I conducted the client ethnography. And so today I'm going to talk about two interrelated factors. The ways in which the intervention engaged with our participants and the relationship between social context and people's capacity to engage with social prescribing. But before I go into that, I'll just talk you through the methods. So we had a fairly diverse sample of 19 participants. Everyone had type 2 diabetes and many had comorbidities. Recruitment for the sample was via the providers who were asked to select a list of potentials for us to approach. 17 participants were recruited in that way, and then after fieldwork commenced, we requested an additional 2 people who'd been more actively engaged in the intervention. Participants were at various points in their intervention journeys. Some had been referred in during its early years, so between 2015 and 17, and others more just prior to or during the fieldwork, which was between November 2018 and July 2020. The fieldwork itself involved semi-structured interviews, including photo elicitation interviews, which were a really useful tool for helping overcome language barriers, as the example of Labani illustrates. Just to add to that, in the exit interviews, we used the intervention's client data as a basis for discussion and reflection about the participants' time in the intervention. The ethnography as well, it involved us spending, or me spending time with our participants as they went about their daily activities. So walking groups, catching the bus, going to yoga, etc. And so of particular value is that by spending 20 months in the field, that really allowed me to develop an understanding of how the intervention couples and embeds with everyday contexts or not over an extended period of time. And so a really embedded vantage point from which to kind of understand our participants' social worlds. So for the findings, so yeah, the first point I wanted to make is that our participants' experiences of the intervention spanned a spectrum, and that ranged from a really embedded holistic intervention through to signposting and more light touch social prescribing. So there was a variation in dose, and that variation didn't always align with our participants' requirements. So what I'm going to do now is talk you through some of those different experiences in order to highlight that contrast. So some participants, especially those who had been engaged with the intervention during its early years, so between 2015 and 17, they experienced a holistic and embedded form of social prescribing, which connected with their circumstances. So for instance, the first quote on the slide is Zahir, and he's recalling his experience of being supported to access benefits. So the link worker ordered the forms, he helped him fill them in, he met him at the office, he went with me for the interview. He was a really good support because sometimes you want to say things, but you don't know what to say. He was there. Likewise, Brenda talks at length about the regular face-to-face meetings that she enjoyed with her link worker, especially throughout her gym referral. So he used to ask all about it, how it made you feel, what you thought about it, and would you recommend it? So the link worker is continuously following up on the referral, and those follow-ups are really designed to explore how the gym is working for her. And that kind of embedded support repeatedly surfaced in the intervention histories of those referred in during the early stages. And then some participants referred into the intervention sort of directly before or during fieldwork also experienced a highly personalised intervention. So for example, Sandeep, he worked night shifts, he drove for a living, lived in a multi-generational household. And as he indicates in his first quote, that really shaped his capacity to engage with the intervention. So it sounds really easy, but it's not that easy when you work full time and you have your family life and so on. Nonetheless, Sandeep had regular contact with the intervention. He really appreciated his link worker checking in with him over the phone, but which suited Sandeep given his other responsibilities. So I've talked to him quite a few times. He's rang me, asked me how I'm doing. I feel like a friend when he talks, and I don't normally talk to strangers. I feel that someone is taking notice and asking me. So because of these regular check-ins, when Sandeep's circumstances changed and he had to reduce his working hours, his link worker was on hand to support him with a number of referrals. So through continuity, the link worker had sufficiently embedded amongst his competing responsibilities, showing the value of persistence and being there so as to be on hand to offer support when people's circumstances invariably change. Another way that the intervention appeared to be embedding in participants' context was via groups hosted by providers. These were a really valued, regular connection to link workers, to other social networks, and to other activities. Although link worker support was withdrawn from these groups just prior to or during fieldwork. But the first quote just shows how life-changing the group was. Before the group, I didn't have a life. They were a really important space for peer support and intervention support to come together. So in the field notes on the screen, the conversation is about a swimming pool opening, and the link worker suggests that one female attendee would enjoy going, but she's really hesitant. I don't know, she says, not right now. And then the other female attendee offers to go with her. And then the link worker suggests they call in for a coffee and see what it's like. And then at the end of the field notes, you've got this really quiet and tactful chat about swimming costume size. So this occasion's a really important example of the value of, of personal issues being addressed collectively. At the other end of the spectrum, many participants in active intervention at the time of fieldwork were signposted to services and information and had less contact than previously observed, and that was irrespective of their requirements. So in the field notes on the screen, so Labani and her family had been struggling with benefits when I first met them, and throughout fieldwork, she asked me for benefits advice, and she eventually got in touch with the link worker, and I visited her shortly after. So you can see that Labani had asked about benefits, and then she shows me 2 A4 printed pages of, and they're listing sort of local welfare rights organizations, and these had been posted to her. But she doesn't know what to do with the information, and actually, like many others, Labani didn't pursue the signposted information. Some participants were referred to other organizations or interventions, such as talking therapies or the gym. But the example of Shirley shows the importance of communication throughout that process. She says she's never heard anything, she's had no contact, and that she wants to know what happens after the gym. So there's a real lack of awareness there, which is in contrast, obviously, to the previous example of Shirley, whose referral was continuously scaffolded by the intervention. So that lack of contact meant that for Labani and Shirley and others, the intervention was out of touch with the ever-changing nature of their everyday lives. So the link worker didn't know that Labani's benefits were sanctioned, or that Shirley's referral was postponed. And that leads me to the second point that I wanted to make today, which is that context matters. Not everybody can benefit from light touch social prescribing, which assumes that individuals are responsible for navigating their wellness irrespective of circumstances. And so I'm going to conclude by focusing on 3 participants in order to convey the ways in which structural conditions shape people's capacity and inclination to engage with social prescribing or health. So Andy's a homeowner and is higher educated. And the first quote on the screen shows how his diagnosis of type 2 diabetes, which he understood to be the result of work-related stress, gave him a fright. And so he got back, or returned, to training, well-being, gym, football. So we didn't need much encouragement to engage, as you can see in the next quotes too. So the support was enough to kickstart him and remind him about what he should be doing. And that familiarity, again, is emphasized in his description of the gym. It was like being back at home. I used to be really fit. His work enabled his engagement too. So he actually benefited from 6 months paid sickness leave. And he's also supported by an employer who's flexible to his needs. So this final quote is about him reflecting on his return to work. His manager would say, get yourself away, have half an hour. They were very, very flexible. So Andy encounters the intervention from an advantageous social position. He brings with him a personal history of prioritizing health, and a present context of secure employment, which together enable a smooth and straightforward trajectory to better health. Tracy had a number of long-term conditions, which she understands to be triggered by the death of her mum. In the first quote, she talks about being 9 stone when her mum died, and then comfort eating as a consequence. She's admitted to hospital several times throughout fieldwork, and that was always connected to her long-term conditions. She often expressed anxiety and uncertainty about interactions with health professionals, especially in relation to some quite major surgery that was coming up. So in the field note, she talks about being nervous about the operation. She's not sure what it involves. She doesn't know what the special diet involves. And then she says, I'm carrying this weight because I lost my mum, even though it was all those years ago. It's not gone, it's with me all the time. Tracy's been linked into several activities, but these are also incredibly anxiety provoking. So for example, in the final field note, she explains why she isn't returning to a social group, even though a link worker had accompanied her there the week before. I haven't got anyone to go with. I don't know what to do with myself. So in contrast to Andy, Tracy's personal issues emerge as, Tracy's personal history emerges as multiple long-term conditions, which are with her all the time. And she encounters the intervention from a context of uncertainty and setbacks, which interrupts or thwarts her journey. Finally, Eddie. Eddie became reliant on food banks during the field work, and began to contact the intervention on a weekly basis, asking for vouchers. So these first field notes are observations at the food bank, and I wanted to draw your attention to how his familiarity with this context is so similar to Andy's familiarity with the gym. So Eddie gets his shopping bag out of his coat pocket and seems to know exactly what he needs to do. The final table's got potatoes and carrots. He continues to walk by. That's me, he says. He heads back to the woman behind the desk and gives her a big hug. Thank you, he says. Eddie was also referred to the gym and a social group and a cookery group, and he didn't attend any of them. He just couldn't prioritize and invest in his future health in ways which aligned with the intervention, which I think is metaphorically captured in his photo and accompanying words. I don't like to look ahead. And in the final quote on the slide, we learned that this was largely due to a benefit system which fixed him in limbo. I just have to wait. They're controlling my life at the moment. So Eddie engaged with the intervention from a context of extreme poverty, and his reluctance to pursue some of his links wasn't to do with a disinterest in his health or a lack of individual motivation or activation. He was highly motivated in using or tinkering the intervention to acquire the economic resources that he needed to survive poverty. Like so many others surviving on benefits, he had other priorities, which lay in navigating his living present rather than anticipated futures. So just to conclude, in this last section, I've emphasized the social context within which people engage with long-term health or social prescribing, in order to highlight that social prescribing journeys aren't homogeneous or straightforward for many. Access to resources allowed some participants to prioritize health, while our most disadvantaged participants experienced multiple setbacks and points of tension. It's well recognized that a strong and supportive relationship with a link worker is integral to the workings of social prescribing. But in addition, given the huge range of social circumstances of those referred into social prescribing, our findings suggest that in order to have an impact, these relations should ideally be robust and malleable or flexible to people's lived realities, which are often in constant flux, and which shape what people can do with social prescribing. Sandy, Brenda, and Zahir's experiences all show the value of interventional support, which persists and tinkers with people's conditions. And finally, I just wanted to pick up on Eddie's story and people living in similar circumstances. Eddie was able to use social prescribing to access food bank vouchers. But of course, we can't expect social prescribing to remove his need to use food banks. So while it helped him negotiate the social determinants of health, it didn't fundamentally improve his position, So I just wanted to finish with this question. Can interventions targeted at individuals alter deeply entrenched social inequalities? Thanks very much for listening. This is there's all my references are on this final slide, which I think will be on the Fuse website after the conference. And I'm now going to pass on to Tessa Pollard, who's going to conclude the ethnographic studies. So over to you, Tessa.
Thanks very much, Kate. And I'm going to pick up on what both Bethan and Kate have said and spend 5 minutes drawing the two ethnographies together to talk about our conclusions in relation to what we saw working really well for social prescribing clients, where some of the challenges lie, as Kate's just highlighted, and again, as Kate has mentioned, implications for what we can realistically expect social prescribing to achieve. So next slide, Kate. So as you've heard in the analyses presented by Kate and Bethan there, we found evidence of clients who'd received highly valued support and also really rich evidence of very dedicated link working. Next slide. And we also saw evidence in both ethnographies of variation in the intervention, a lot of heterogeneity. And part of that variation derived from external factors which shaped social prescribing and put constraints on the efforts of link workers. So in Kate's data, we saw evidence as well that shifted over time. So the experiences of service users showed that there seemed to be a drift towards a lighter touch intervention. And that coincided with pressures clearly seen in Bethan's analysis for link workers to spend more time generating referrals, which meant in turn less time with clients. And those pressures came to a great extent from problems embedding the intervention within primary care in some participating practices, and from the funding structure, and that included changes to the funding structure over time, which increased pressures on the providers around referrals. Next slide. So we think some of our most important findings are those that throw light on the opportunities for social prescribing to have an impact on health inequalities, which is often cited as an aim of social prescribing. As we've seen, at its best, social prescribing helps some disadvantaged service users negotiate some of the challenges that they faced and link them to services and community groups from which they benefited. But, as Kate emphasised, it couldn't address the deep structural disadvantage experienced by some of our study participants, and nor could we realistically expect it to. And as Kate showed, we also found that the most disadvantaged service user participants in our study were often not in a position to benefit from a lighter touch, but in particular, version of link working that tended to emphasise personal responsibility for making lifestyle change. And next slide. So what are the implications of the qualitative findings for social prescribing in general? First of all, we suggest that link workers offering intensive support to service users, including careful support into community groups and activities, are most likely to have a lasting impact on service users' lives. And this suggests, on the next point, that in rolling out social prescribing more generally, nationally as is happening at the moment, it's really important that attention is paid to giving link workers the opportunity to work in this way, and we've identified some of the sources of pressure that can mitigate against this way of working. Having said that, I think it's worth remembering that the model of social prescribing we studied was distinctive in the way it was set up, and importantly, actually, it seems likely that NHS link workers could face much higher caseloads than the link workers we studied, and that clearly raises concerns given our findings. And then finally, we argue that while social prescribing is a valuable intervention, it's really important that we don't expect too much of it. It's unlikely to be able to significantly change the lives of those in the most deprived circumstances, especially following more than a decade of austerity in the funding of services and benefits. Next slide. And then finally, I just wanted to highlight that our conclusions resonate with 4 recent reviews. And if you're interested in following up on these issues, I suggest that you read our paper, the first paper from the ethnographic studies, but also these papers, 3 of which were co-authored by Stephanie Tierney and Karen Husk, who are 2 of our panellists who'll be speaking later on. And those papers also identify other aspects of social prescribing that should be investigated in depth, including how social prescribing is experienced by healthcare professionals, including how referrals work for healthcare professionals, and very importantly, how social prescribing is experienced by those working in the voluntary and community sector, which is where much of the burden of delivering social prescribing lies. And this study didn't address either of those areas, although we as a team are undertaking further research which does. Okay, thank you very much. Yeah, questions would be great later on after the panel session. Thanks.
Thanks very much, colleagues, for that insightful overview of the link workers and the clients' perspectives, and for raising some important questions which we'll pick up in the panel discussion later about the role of individual interventions in trying to tackle what are quite embedded structural issues of inequalities. We've now got our final presentation, which is an additional project which was done in response to the emergence of the COVID-19 pandemic. So this is Dr. Stephanie Morris, who's a researcher in anthropology at Durham, presenting work that she's done with Dr. Jo Wildman from Newcastle University, talking about the experiences of social prescribing during the COVID-19 pandemic. So welcome, Stephanie.
That's great. Thanks very much, Claire. So yeah, as Claire just said, I'm Dr. Stephanie Morris, and last year I joined the team to conduct this additional study about social prescribing during the pandemic, and myself and Jo Wildman led the analysis for this study. So this study was developed in response to the first UK lockdown for 3 reasons in particular. First, it was clear from the outset that clients within waste wellness often have multimorbidities and were likely to be classed as vulnerable to infection, serious illness and potential mortality from COVID. This group were therefore also more likely to be asked to shield or would take extra self-isolating precautions and thus be at higher risk of loneliness, depression, anxiety and reduced physical activity levels, which were issues that were often already existing in this population. And third, that social prescribing was highlighted as having the potential to be able to deal with social isolation and other increased health challenges associated with the pandemic. So this study had 3 aims. First, to explore service provider accounts of how waste wellness adapted to meet clients' needs in the first wave of the pandemic. Second, to explore the impacts of the pandemic on people's health and well-being and how people managed during the first months of social distancing restrictions. And third, to explore clients' accounts of how the intervention worked for them during this period. So we collected our data between the 1st of May and the 13th of July 2020, with 1 additional interview with a staff member conducted in September. And during this time, clients and service providers were living and working under changing government guidelines and had experienced the UK lockdown from the 23rd of March to the 12th of May 2020. And it's noteworthy here to mention that the support bubbles, where a single adult household were able to join with another household, were only created on the 13th of June, and as such, many of our participants had not experienced a support bubble at the time of their interview. So we conducted 29 telephone interviews with clients who were already taking part in the EQ5D study that Nikki presented at the beginning of this seminar, and a further 15 interviews with clients who were part of the ethnography that Kate's just talked about. Now, our colleague Jane Jeffries conducted 13 interviews with service providers, including 8 managerial staff and 5 link workers during the beginning of the pandemic. And we followed a thematic approach to analysis to identify patterns relevant to the research questions, and the data was analysed as a snapshot in time during the changeable circumstances of the pandemic. So now moving on to our findings, the client sample comprised of 44 individuals. Clients were mostly over 50 years of age and just over a third were retired. Over half of the sample claimed some form of welfare benefits, mostly related to their health status, and nearly 1/3 of our participants were unemployed, often due to ill health. Nearly 2/3 reported an annual household income of less than £20,000. Now, 9 participants reported having a single long-term condition, but the remaining 35 had multiple conditions, which most commonly comprised type 2 diabetes, hypertension, COPD, anxiety and depression. And some had a much more complex mix of long-term conditions, including MS, vascular disease, heart failure, epilepsy and cancers. Now, all of our participants had been in the intervention for at least 12 months, and as such, many had already moved to less frequent engagement with their link worker. So just before the national lockdown, the service providers switched to remote working and intervention delivery. The intervention responded to the pandemic and to the unmet needs in the community, and link workers began calling people who were on council and GP surgery vulnerable lists. Now, this work entailed focusing on immediate help and referrals to other services, such as food and medicine supply deliveries, checking people understood COVID-19 government guidance, and also that people were coping and managing okay. The service providers also explained how conversations with existing clients altered in the early months of the pandemic as they responded to people's anxieties and concerns around COVID-19. Advice and support around COVID became like an immediate priority, but there were also attempts to balance this with supporting people not to relapse or go backwards with their condition management. So retaining contact with all clients was expressed as a priority as well, but this was a really huge task due to existing high caseloads and the new vulnerable list clients too. So managers and link workers said they were balancing contacting clients who they knew had already had very high levels of need, whilst also aiming to contact their entire caseloads, including some who had previously been discharged. So link workers and staff reported key challenges and opportunities during the early months of the pandemic. Firstly, there were challenges with engaging digitally excluded clients. So some said they found it difficult to refer digitally excluded individuals to any services at all, as most were now online. Many other clients weren't particularly tech savvy or simply were not interested in online service provision because it didn't work for them. And some link workers said that they attempted to adapt their delivery to these people, which included sometimes posting hard copies of information to them at their home addresses, but this was often personally funded due to remote working. And it also didn't manage to deal with any kind of literacy issues, which some clients had. So there were many difficulties there. Second, many link workers were unclear about which services were running remotely as things were constantly changing, and they expressed difficulty fulfilling their linking role when usual link services were unavailable. Third, using telephone calls during lockdown meant that clients were generally easier to access, especially during the lockdown, but some clients were said to be more engaged in the intervention. And some link workers said that they felt the intervention had become more person-centered because it now bypassed the difficulties that some clients had with actually physically getting into the GP surgery for appointments. However, other link workers said that their clients preferred face-to-face contact and expressed difficulties with building rapport and using their therapeutic skills over the phone. And that was especially if they had not met the client in person before. So one link worker said, well, when we do the first assessment with someone, the face-to-face of that is so important because you're introducing yourself and what the service is. You need to build that rapport. Everything has changed, so you can't see what people are doing, body language-wise or face-wise. We're told to hold silences, but that's very different on the phone. And fourth, some link workers express creativity and innovation in support of people remotely, such as one who was trying breathing activities on the phone with clients with COPD as a substitute for attending initial healthy lungs classes. And others said they felt they were responding more to client need and supporting and advocating for their clients more. Now, with regard to clients, we found that over half of the sample experienced struggles and difficulties with their health and well-being during the first wave of the pandemic, and some experienced significant disruptions to their employment and their finances. A lockdown and the fear of infection increased the practical and emotional challenges of living with a long-term condition. These include social isolation, inaccess to routine healthcare and monitoring appointments, and inabilities to do self-care such as physical activity. Those who were shielding, living with complex conditions and in disadvantaged circumstances in particular, tended to experience particularly worse physical and mental health. And we also saw varying levels of coping with the pandemic. And people tended to cope better when they were able to access and deploy social, financial, digital, and cultural forms of capital, as you would expect. So when it came to clients' experiences of the intervention, we found that people had varied experiences too. So 2/3 of our sample recalled no contact with a link worker since the lockdown. Of these, about half were coping reasonably and said they didn't need any support, so that was absolutely fine. But the other half were not coping so well, and many of them didn't actually know what the intervention could do to help them at this time. Now, the third of our sample who had contact with their link worker since the lockdown most often received check-in calls, which were very, very appreciated. And 3 clients received really quite valuable support, including help with accessing a food bank, been given resources for condition management, and also some emotional support and linking for severe mental health, as is seen in the case of Jill here. So Jill had very complex health needs and social circumstances and had received consistent support from the same link worker for several months prior to the pandemic. She had been a full-time carer for her partner until he recently went into a nursing home where he had died from COVID-19, and she now had the added stress of navigating the benefits system. She said the following about her link worker: "I thought she was the kind of person that I could actually talk to, and she has been quite a valuable person to me. Well, it is somebody I can talk to who knows exactly what I've gone through. When she rings up, I always feel a lot better after I've been speaking to her, but especially at the time where I was going through the devastation of losing Jim and everything. Oh, she was just brilliant, you know. She has given me so much encouragement, and she tried to get me to see the positive side of things as well." Now, at the time of the interview, Jill was speaking to her link worker every other week, and she knew exactly when to expect her calls. Her link worker was helping to arrange additional counselling, as the previous 6 sessions she'd been provided had barely touched the surface of Jill's trauma. Now, we see here with this example that the link worker client relationship was really key for the holistic support that Jill received both before and during the pandemic. But for some clients, their journeys with the intervention were perceived to be on hold, where they were just waiting as they could not physically see their link worker or be linked to services that they required. Take, for example, Derek, who was living in a small 1-bedroom flat on the 18th floor of a tower block with no outside space and regular antisocial behaviour. He had heard from a link worker during the pandemic and appreciated them checking in, but he really hit the nail on the head when he explained that their hands are tied with what they can actually do. So his gym referral was on hold, and his legs had been getting worse during the lockdown due to inactivity. He said, "If I see them one-on-one, it's a lot better. I'll get my point across a lot more." And he explained he was becoming depressed and had been comfort eating high sugar foods that he knew he needed to reduce as it would negatively affect his type 2 diabetes. But his poor living conditions, his declining mental health, and social isolation from his family and partner hindered any positive practices related to the good advice that he had received from the intervention. So there's also people who had been struggling with going back to square one. So take, for example, Rena, who was living with asthma, anxiety, and heart failure and had a limited social network around her. She experienced huge disruptions to her daily life in terms of work and resources for managing her mental and physical health, as all ceased when she was advised to shield. Prior to the pandemic, she had made dramatic improvements to her health and well-being with help from her link worker, who provided really good information on activities. She'd gained confidence in going out and doing things after a serious decline in her health. However, when that link worker left the organisation, she said that support dwindled off, and during the pandemic, she'd not heard from her new link worker and appeared very nervous about contacting them. She said, "Oh, I'm not very good at, if she's not expecting me to call, I don't know. I don't know her. I knew the old one. I knew the old one quite well, but I don't know her." Now, this change in link worker and therefore limited client link worker relationship and lack of contact meant that Rena and some other clients' changing circumstances that had happened during the pandemic and their struggles were not identified, and their support was not provided. Now, Rena felt that she had disappeared and her only means to cope was to put up with social isolation. So overall, we found a significant proportion of participants experienced negative impacts on their health during the first wave of the pandemic. People who were shielding and living alone, had complex health issues, or were living in the most socioeconomically deprived circumstances tended to struggle the most. Now, the social prescribing intervention in this study set out to respond very sensitively to the needs of local people during the first few months of the pandemic and delivered much needed support to many. However, remote delivery and a lack of in-person services such as gyms and groups meant it was very difficult to stop people feeling that they have gone back to square one with their condition management. Limitations likely created by the sheer amount of need during the pandemic and high caseloads and staff turnover meant that while some clients experienced check-in calls and substantial help and support from their link worker, others did not have any contact and did not know how the intervention could support them during this crisis. Now, our findings suggest that person-centered, holistic, continual support and supported linking, like was seen in the case of Jill, is likely to be more beneficial for people living in the most complex and disadvantaged circumstances to help them navigate those social determinants of health. Now, enabling consistent and frequent link working and ensuring services are accessible to digitally excluded groups will likely help social prescribing succeed in alleviating the additional health challenges connected with COVID-19. So that's all from me. Thank you very much for listening.
Thank you very much, Stephanie, and thank you to the other presenters as well. So that's the first half of the afternoon with the overview of the results of the project, the quantitative and cost of benefit and value data, various qualitative presentations about experiences of service users and link workers themselves, and then a very powerful presentation there by Stephanie about how COVID-19 disrupted the service in some ways, but where it was consistent was also a valued support mechanism for some of the most vulnerable people during the pandemic. We're very nicely only a few minutes running over time, so an extra congratulations to panelists, to speakers for that. I suggest we have our comfort break, and it's around 2 o'clock now, so I suggest if we come back at 2:10, we can then have the panel in which we'll have some reflections from a number of colleagues on what we've heard so far, and there'll be the opportunity for everyone to present their questions in the chat function. So I'll see you all back here at 2:10. Thank you. Welcome back, everyone, to the second part of our workshop today on the impact of the social prescribing intervention Spring North East. And now we're going to go into a panel discussion and the opportunity for questions. I'm really delighted that we're going to have several panelists joining us to act as discussants and to have their reflections from a policy and practice perspective on what we've heard so far. I'm going to introduce each one in turn, and they're going to speak for a couple of minutes in terms of what the findings might mean from their perspective and for the sectors that they represent. So I'm just delighted that Jane Hartley from the voluntary community sector is going to join us first. Jane is currently the Health and Wellbeing Associate for Voluntary Organisations Network North East, the North East Regional Social Prescribing Facilitator for NHS England, and the Thriving Communities Regional Coordinator for the National Association of Social Prescribing. And Jane's going to talk about the implications of the findings in terms of the future of social prescribing in the UK, particularly reflecting from a voluntary sector perspective. So Jane, absolutely delighted that you can join the Fuse research seminar today and be interested to get your thoughts. Thank you.
Hi everyone. I've just got a couple of minutes to share my reflections, so I'm going to try and share my screen if possible. Can everyone see that? Yeah? Good, okay. So I've been particularly asked to focus on what the implications on the findings are from a voluntary sector perspective. So I've chosen kind of key things that kind of jumped out at me and that are indicative of a wider picture that we have for the voluntary and community sector. You'll have seen that there were comments from link workers about potentially the lack of variety of options in terms of voluntary and community sector activities and networks to actually refer and send people to. And, you know, that famous phrase, if you have lots of travel agents but no holidays to refer people to, then it's a bit pointless to have lots of travel agents. And, you know, one of the things that I think we are in danger of doing in terms of the NHS's agenda in expanding and rolling out the presence of social prescribing link workers within primary care, and we're seeing, you know, huge increases in social prescribing link workers being placed in primary care, which is great. However, if that is the only component that is being invested in, then social prescribing just isn't going to work, because you'll see in terms of these 5 essentials of social prescribing, which, you know, it just doesn't tick unless you've got all of this, that you can talk about having connections to personal and community networks and third sector support and buy-in from referring professionals. But if you haven't got a transfer of resources from the statutory sector to the third sector and community building and service development, then it's going to fall flat on its face. Many of the social prescribing activities are delivered by smaller community groups at neighbourhood level, and they require funding to sustain and absorb the increased demand that is going to be created by a wider range of professionals, particularly in primary care, link workers who will be sending people to them. And I think there's been an expectation that the voluntary sector will just continue to absorb more and more referrals, and at the end of the day, they can't do that without the resource to support it. There was also, in terms of that, the findings around the impact of COVID-19 in terms of service providers. I just wanted to, you'll have seen these slides which talk about how the sector had to adapt its delivery, and some of the work that we did in support of the qualitative work stream in the Health Inequalities Impact Assessment for the North East, working with many colleagues who are on this call today, kind of corroborates some of the findings that you found through this research, but perhaps took them from a wider cohort of voluntary sector providers. And, you know, the most critical issue facing the sector was their ability to survive through COVID, and actually needing financial support. And I think we've now reached a stage where, yes, there was short-term financial support for the voluntary and community sector, but how is that going to support them going forward? Because much of that support has now ended. But some of the positive outcomes that came about were around finding new ways of using technology to deliver services and delivering remotely, but also increased collaboration and partnership working, particularly across sectors. And I think there was the new light that was shone upon the voluntary sector, and link workers working with the voluntary sector, you know, to get through the crisis that COVID-19 presented. I think threats that were identified were around the potential to increase health inequalities through digital exclusion of those most in need, the challenge around funding bodies prioritising COVID-19 at the expense of other areas of need and other services, and the withdrawal of services that are often the only source of support for many vulnerable people. So some of that resonated for me. There's some of my contact details. I think I've had my 3 minutes. Thank you very much.
Excellent, and well timed. Thank you very much, Jane. And so questions in the chat, please, for the presenters, and also if you have any comments that you'd like to raise with the panelists. Jane's just spoken, and we're now going to have Our next discussant is Martin Cattermole. He's head of the evidence unit of the personalised care group at NHS England and NHS Improvement. And Martin's going to talk about what implications do the findings of the study have for the future of social prescribing, reflecting particularly from an NHS England perspective. And we saw in Jane's presentation the kind of focus on social prescribing as part of the long-term plan. So Martin, be delighted to hear your thoughts on what you've heard so far today.
Okay, thanks, Claire. I'm Martin Cattermole, working at NHS England and Improvement. There was one small correction, by the way, to the first set of slides. The 1,000 link workers were by March 2021, which I think was achieved. So just for anybody who's not familiar with the programme, it is going to be a lot bigger than that. It would be heroic for 1,000 link workers to do everything that we're hoping for. So, I mean, the first thing I want to say is that we really welcome this evaluation. It's fantastic work by Waste to Wellness and you as evaluators, and we're really keen to listen and learn to what you found out. And a lot of the issues you've raised are ones that we do recognise. So the first thing really is, if we stand back, it's a really positive and insightful study, and quite unusual because it has both really rigorous quantitative approaches and in-depth qualitative work. And I think one of the things I'll be highlighting to my colleagues is that it's great that we do have some clear evidence of health benefits. The HbA1c result, as John says, is quite exciting, and people will be really interested in the findings about service use as well. There's three issues, though, that sort of stand out for me from what I've been hearing this afternoon. I think the first one really is this does highlight the importance of how we think about the design of social prescribing, whether at a local or national level. So who is it that we're trying to reach, and what is the actual nature of the support that we need to offer people? So I think the kind of challenge that you've posed us is, you know, is social prescribing going to be something that needs to be really intensive and tailored and focused on people who face the greatest exclusion, even though, as you say, it can't then remove poverty or all the other social determinants of health that people face. And as Jane says, what else needs to be in place alongside the link worker? So that's all really about the design of schemes. I think the second thing I wanted to highlight, and it's a particular kind of strength, I think, of the Waste to Wellness and the evaluation, is that we do need a systematic approach to data. So we can't actually understand who we're reaching or what results we're getting if we haven't got in place the kind of management information that I know Waste to Wellness have, and the use of the kind of measures that you've done in the study and that are built into the scheme design. And I think the third point really is kind of what are the benefits we're actually trying to achieve here. I think, again, you've posed us the issue about whether it's quite narrow, is it really focused on health benefits, in which case, as John said, it's hard to kind of make a case for cost effectiveness just based on that, or really should we be looking at much wider benefits, and indeed in terms of funding, kind of funding from lots of other sources at the health service as well. So it'd be fantastic, Claire, to talk about what else we could do at a national level. Some things we're already doing is there's a lot of effort going into improving supervision and training of link workers right across England. There is some investment in the voluntary sector through the NAST Thriving Communities programme, which is a kind of a start at addressing the challenge Jane's posed. And we're doing a lot of work on improving the data and also putting in place a national evaluation. This evaluation's told us a lot about what's happening in Newcastle, but we need to get a clearer picture across the whole country. So the national evaluation's going to kick off probably around the beginning of next year. So that's all from me, Claire. Thank you for inviting us.
Thanks very much, Martin, for those reflections and for picking up some of the key issues from the presentations. We're now going to have Professor Chris Drinkwater. who's going to again speak for a couple of minutes. Chris was a GP in the West End of Newcastle for over 30 years, and I'm sure many colleagues listening today will know Chris personally. He's also Emeritus Professor of Primary Care at Northumbria University, a Fellow of the Royal College of GPs, and a Fellow of the Faculty of Public Health. And as we can see from the lovely banner behind him, he's also Chair of Ways to Wellness. So Chris, really great welcome from us, and thanks for joining today.
Thank you, Claire. And the homework you set me was, what implications do these findings have for the delivery of this type of intervention? I think two things about this type of intervention. Are we talking about an outcomes contract, or are we talking about a social prescribing intervention? Because this was in fact both. Outcomes contracts, you're paid only on achieving particular outcomes, and I'm not suggesting that everybody should move to outcomes contracts. This was really very much set up, and as you said at the beginning, it took us 8 years to set this up, was about proof of concept, and we needed an outcomes contract based on our logic model, which said that unless you improve people's quality of life, you are very unlikely to affect their health behaviours in terms of use of health services. And that in effect as what this research and what Ways to Wellness data has in fact demonstrated. So I think in terms of the future of these interventions, I would pick up what Martin's just said. I think we need to spend a bit more time on design of social prescribing and a targeted approach, linking it to the NHS's interest in population health management and looking at primary care networks as the hub around which you run population health management at local level. And for me, that means, one, you're going to need more resources for primary care networks in disadvantaged areas, because those are the areas where you will need a more intensive input from link workers. And two, I think there is a strong argument for targeting this at particular groups within the population. We very deliberately chose people aged 40 to 74 with specific long-term conditions. That was partly around proof of concept, but you might want to look at a more targeted approach around people with mental health problems, around older people, and particularly post-COVID around young people who are often suffering from mental health problems, stress and isolation. So I think there's a population health management targeted approach that we need to think about. I think the other thing I'd like to talk about, Jane's mentioned lots of travel agents and no holidays. I think for me that one of the things that this is demonstrated, particularly the ethnographic work, is that the link worker is the intervention. Unless the link worker bit works, the activities don't work. So the link worker is the intervention. And there are some interesting suggestions in that ethnographic work that we ought to be picking up on the link workers actually running groups and getting more skilled at running groups and running their own activities, because they have the initial contact with the individuals. They can match and pair people up and look at peer support models. So I think there's some issues for me about the link worker is the intervention. Where do link workers best sit? Do they best sit employed in the NHS and primary care networks and general practices? Or do they best sit in the voluntary and community sector? And again, from my experience within Ways to Wellness and working with our link work providers, who are a combination of voluntary sector, social enterprise, not-for-profit organizations, I think there is a strong argument that if you want to build local assets in defined populations targeting particular groups, then you need to work with the voluntary and community sector and provide them with the resource and support that they need to employ and manage link workers effectively. That's my 3 minutes basically.
Thanks so much, Chris. Some interesting thoughts there, and obviously reflecting and linking back into to what Jane and Martin was saying as well. And next intervention comes from Dr. Stephanie Tierney, who's a lecturer and senior researcher with the Nuffield Department of Primary Care Sciences at the University of Oxford. Stephanie's recently published on the ethics of social prescribing and the role of volunteering in social prescribing. So this could be an interesting continuation of what Chris was talking about. She currently co-leads the National Institute for Health Research funded project specifically looking at the link worker role. And Stephanie's question was about what are the implications of the study today for evaluating social prescribing in the future. So thank you for joining us, Stephanie, and over to you.
Thanks, Claire. And for me, first of all, it's highlighted, as Martin mentioned, the importance when evaluating social prescribing, the importance of qualitative and quantitative data in the same project. Because we are studying a complex intervention in terms of social prescribing that has a range of different actors who are interacting at different levels in different ways, at both an individual but also a systems level. So I think trial, experimental, numerical data can tell us so much, but they won't tell us things like how to create that buy-in to the link worker role from GPs, patients, the voluntary and community sector. It won't tell us how to optimize uptake of a referral to a link worker when somebody's referred, and how we message and communicate the role of the link worker to patients. And also that more quantitative data won't tell us about the mechanisms that are important for enabling link workers to develop credibility within a healthcare team. And I suppose that is where the qualitative data really comes into its own, and it complements that more numerical data by helping us to explain and comprehend them more, the more contextual factors that have been talked about today. And also to theorise about why social prescribing interventions might work in some settings for some individuals, but not for all cases. So for me, understanding social prescribing going forward, I do think we need to incorporate, as is often the case in evaluations, that qualitative and quantitative data. The other area I wanted to just focus on is the importance of outcomes. And for me, the studies raise that perennial question of what we assess in terms of social prescribing, how and when. And there is this expectation that social prescribing will improve health outcomes, but as has been discussed today, that's not necessarily the main or the goal, the direct goal of the intervention, which is more about addressing those so-called social circumstances and addressing those social determinants of health that John referred to earlier on today. And it's anticipated then through addressing those more psychosocial circumstances that health behaviours will improve and health outcomes will follow. But I think we need more information about how long we might expect those psychosocial improvements to arise for patients. And that might then indicate how long we need to collect data for, because obviously if we follow up things too short, if the follow-up's too short, we might miss those important changes in psychosocial variables, but also in those health outcomes as well. It would be interesting to, or it was interesting to hear the research talking about improvements, statistical significant reductions in HbA1c, but I wondered what that meant in terms of social prescribing and how social prescribing fitted into that. Was it about somebody taking an interest in that person's life, meaning that the patient felt less alone, they had somebody that they could offload to? Or was it about having that connection to community offers that then gave people a purpose in life? It meant that they developed their social capital, were maybe distracted from their physical conditions, and maybe became more active. So I think in thinking about outcomes and this, as I say, perennial question about what we measure, how and when, it's important that what we're measuring has relevance to the patient and is what they're expecting from the link worker addressed in what we're measuring in terms of outcomes. And then finally, in terms of outcomes, I think we need to measure how far link workers are able to work in a person-centered way, because social prescribing, as been mentioned today, is part of that comprehensive model of personalised care for NHS England. So how do we collect data on how far link workers are able to deliver personalised care, thinking about things like how referrals are made, what metrics they're assessed on, the support that's available in the community for them, the time they have available to work with different individuals, their caseloads, and what peer and supervision is available to them to look after their own well-being. So as I say, the two things that sort of came out of the research and thinking about work going forward is mixed methods or bringing together qualitative and quantitative data, and that question about what we should be measuring, how, when. Thank you.
Thanks so much, Stephanie. Some interesting thoughts there on how we can, better evaluate in the future, building on this great evaluation, obviously led by the North East team. And then our next speaker and final discussant is Dr. Karen Husk, who's an Associate Professor of Health Services Research at Peninsula Medical School, University of Plymouth. Karen leads a programme of social prescribing research for the National Institute for Health Research, has written on the evidence about social prescribing, and is the current lead for the National Academy for Social Prescribing's Academic Partners Collaborative. And Karen's going to talk about what the implications of the study of Spring North East, what do they have for evaluating social prescribing in the future. So welcome, Karen. Thanks for joining us.
Thanks, Claire. So hello, everyone. I just wanted to point out as context that I'm in my daughter's my 3-year-old daughter's bedroom. So we've got owls and Peter rabbits and things. But and I should also point out that I had the same exam question as Stephanie. And I wanted to focus a little bit on some of the positives, some of the negatives, and the implications for future research in this area. So firstly, I wanted to reiterate the point that Martin made so well, that controlled evidence is really high on the priority list for policymakers, but also lots of other people in this area. We hear repeated calls from all over the social prescribing pathway that this type of evidence is really useful for making the case or for convincing particular sectors. So there's a real benefit of this study. So also the quantitative evidence today, it fits well with developing trial evidence relating to the particular activities that people end up doing as part of social prescribing. And it helps us in putting together the complex evidence base along the social prescribing pathway. And it's a really important piece of the puzzle. Linked to the first point, the inclusion of a clinical outcome alongside wellbeing is of real interest and value to a lot of people in these pathways. We've heard from those trying to develop and implement services in multiple areas that robust, clinically linked evidence is what they require. And so this is a real step forward. So all that said, there are some areas where I thought we would benefit from some discussion. And whilst this study is really useful, it is actually quite narrowly bounded in some ways. So we know with clarity the effectiveness of this particular section of the social prescribing pathway for a particular cohort, but we need to make sure that we develop the links and how this study dovetails with other areas for social prescribing so that we're able to align the evidence and bring that breadth of knowledge together. Secondly, I agree with John earlier that there is a point to be made about outcomes and their simplistic use, often simplistic use, sorry. So the clinical element is clearly beneficial, but there should be some broader discussions around the health service use outcomes, I thought. So there's been much written on the intention of social prescribing to decrease service use and turn pressure off the NHS. However, the picture's obviously more complex, and studies have shown that if you increase patient activation, it can lead to increased service use as well. So we down here were wondering about whether measures around healthcare use as an appropriate measure might be turned on its head so that we can start to look for how service use might fit particular groups of patients or individuals. So would you anticipate those with complex needs who've had limited contact so far, you'd want that that service use to increase, whereas for other cohorts you'd like service use to decrease, and trying to get into those measures would be really useful for future studies, I think. My last point is to echo Jane, and I know Jane made this case really clearly, but the importance of considering the capacity and impact on the organisations delivering the activities is central to all of this research. It's often the case, and I'm certainly not making the case here, that the VCSE is considered free, available and limitless to the NHS services that rely so heavily on them. Given what's happened over recent years, the VCSE's resilience is at an all-time low, and understanding how we can develop those longer-term, secure, greater funding for those links is absolutely essential.
Thanks so much, Karen. Some really strong and important points there, and it's quite nice to come full circle to reflect back on what Jane started this discussion section with, so thank you for that. If I could ask all the panelists to keep their cameras on, and also for today's presenters to also put your cameras on, please, now as we're entering the more kind of question and discussion phase, that would be great. And before I've got several questions have come in from the audience, but before I go into that, I just wondered if any of the team, the research team, the presenters would like to respond to any of the comments, points that have been made by the discussants around the evaluation. Thanks, John.
Yeah, can I start? So thank you. Thank you all of you. I think some really, really, one, I'm pleased that you got some value out of it. That is really, really rewarding. Two, I think you make some really, really important points, and I think it's one of those. And the standard cliche of more research is needed is always a sort of disappointing way to end any project, but it often is the case that it takes you 3 years to get to the point to saying, actually, now we really start to know what questions it is we really should be asking, and some of these things that come down. So I just wanted to say, I think what Martin was saying, I'm just going to concentrate really on the sort of quantitative side of things. So I'm going to pick up mostly on what Martin, Karen and Stephanie had to say about the design of social prescribing. I suppose that fits in actually partly with what Chris was saying as well, that it is that what do we want it to do, and what is its chief goal, and I don't think that's necessarily clearly well articulated, and I think it was a challenge that we had, and I think I'm going to sort of say here, I think it's a challenge of the way that research is funded, in the fact that we had to have a primary clinical outcome as part of this to sort of make it a viable project. And in a way, that's a little bit of a shame in the research side of things, which sort of narrows the questions down that we can ask. But I also think that element around the systematic approaches to data is really, really important as well. And then I think, Karen, you were sort of saying about the nuances, especially around some of this healthcare use. Absolutely, I think that's a really, really important point. And I think it to some degree fits in with what Stephanie was saying about the issue of mechanisms, and it sort of ties into that, and again that use of the quantitative and qualitative to try to help to unpick some of those issues. And then I think finally, just to say, Chris's point about the link worker, and again I think this is my point, I've sort of tried to say this, not only what is the treatment, so not only who is being treated, but what actually is the treatment, because there are actually many levels of treatment here, and it is very, very heterogeneous, and I still think that could be resolved better in evaluation. And finally, I think, Jay, the thing about is the voluntary sector really being well looked after in all of this? And again, as an economist, always think about the unintended consequences is that you introduce these things, but you don't know how they're going to the knock-on effects of areas around you, and that some areas of the country, I'm sure that there's far greater capacity for people, especially when you've got diversity of people using link workers, or using social prescribing, diversity of all sorts of dimensions, to make sure that diversity is represented in the community sector that can then support them, which will be a challenge for different areas and different places. So, but again, just wanted to say thank you.
Thanks, John. Do any other presenters want to respond to any discussant comments?
Yeah, can I just respond in relation to the qualitative data? I was really pleased to hear Martin and Chris's comments and their reflections on the need to think about what we expect from the link worker role. There's a lot of rhetoric around social prescribing that tends to be really ambitious and sort of tasks link workers with both addressing inequalities in different ways, I guess, by supporting and offering personalised support to clients, but also this idea that it's about motivation and helping people to take control and empower them to take control of their lifestyles. And those are actually quite different things. So I think we just need to think about what clients really benefit from and how we can enable link workers to deliver that. So it's just sort of unpicking that link worker role a bit more is really something that I think we'd like to see come out of our research.
Thank you. Okay, I think we'll now go on to the questions that we've got from the audience, of which there are lots. So I will be doing my best to screen through them, and I'll read them out. I might try and direct them to a member of a panel if I can. If not, if you could say, if you feel that you could answer just by raising your hand, that would be great. So the first one is from Jasmine, who's Director of Making Changes Northeast, an organisation that aims to combat loneliness and isolation by building communities through education and experiences. And her question is about how would her organisation be able to become a social prescriber, and how could they link up with other social prescribers? So I wondered if Jane or Chris might be able to give a quick answer on that one, but I'm sensing it might be something that Jasmine might need to contact one or other of you about. But I wonder, Jane, is that something that you'd be able to answer? Thank you.
Yeah, I mean, in my role as the Thriving Communities Regional Lead, which is about supporting primarily the voluntary and community sector, smaller voluntary and community sector, to sort of, if you like, play a part and engage with the social prescribing agenda, we get a lot of these questions, and I think it throws up some stuff that came up before, which is like, what are we talking about here? Are we talking about the social prescribing link worker, or are we talking about the end activity? And you know, if the question is about how do I connect with social prescribing link workers to make them aware of my services, then that can often be a challenge. But you know, it can be as simple as Googling local GP practices, and actually on their website they may well have the link worker contacts if they don't get in touch with the practice. And you know, it's really basic stuff. We also have regional learning coordinators employed through NHS England, who support peer networks of link workers. And you know, if you want to contact me afterwards, then I can perhaps contact you, you know, get you in touch with them, and through the peer networks they can make individual link workers aware of services. But I think, you know, if it's about becoming a social prescriber or a link worker, I mean, I know they're called different things in different arenas. We do have a lot of third sector or voluntary community sector organisations who employ link workers, who are then placed within primary care or within other settings, who are doing the kind of the support and referral activity. And if that's what they are talking about, then that's probably a different journey, and that's about looking at opportunities that are put out by primary care networks to employ link workers. It's also looking about what expertise do you have within your organisation to be able to perform that function. I don't want to sort of hog the conversation. It might be better to contact me afterwards about that. But I was quite interested in what Chris was saying about the link worker possibly being the intervention. And some of your feedback was saying we don't have enough time to actually provide support to individuals, and that there isn't enough understanding with clinicians around the need for spending intensive time with particular individuals. And I would say that we've recently, through NHS England, they've just done a social prescribing link worker survey. And the initial findings, I've literally just received a presentation, which Martin may even not have seen yet. But, you know, the feedback we've had has been that a lot of link workers are saying that they find that clinicians do not understand how much time they want to spend or need to spend with individuals, and that it's very hard for them within their, particularly the primary care link worker roles, to actually enable that level of understanding, free up time to be able to do that. So I think we need to consider all that as well.
Thanks so much, Jane. The next question is about the funding of the Waste to Wellness intervention. So I'm just going to ask Chris if he could talk a little bit, because it said that the social impact bond supported Waste to Wellness, and is this something that's been replicated elsewhere, as that might help with some of the issues that Jane mentioned and Kieran mentioned about the funding problems within the voluntary sector. So Chris, thank you.
Just picking up on Jane's point before I go on to Marcella's point, there's an issue about what is the dose of a link worker for which particular client, because if you're looking at a population health management approach, then there will be some people have greater needs than other people. It's the Marmot proportionate universalism. And how do you decide who's going to get the most time is always a vexed problem. It's troubled GPs forever, basically, in terms of if you spend more time with one individual, you have less time for other individuals. And so I'd go back to Tessa's point, we need a better understanding of what the link worker is trying to achieve, and we need a better understanding of what dose, if you like, of link worker is required to produce the sort of outcomes that we're looking at. That leads me into outcomes and outcomes contracts. This was a social impact bond, essentially, that we put together with funding from a variety of sources, including investors, and clearly repayment of investors was part of that. That's all been done successfully, so the investors have got their money back and interest on it as well, bit like your house and a mortgage. And to an extent, we're a special purpose vehicle. We set ourselves up as a charitable foundation with the sole aim of running Ways to Wellness, a social impact bond for social prescribing for people aged 40 to 74 with specific long-term conditions. We worked out the outcomes that we wanted people to meet on the basis of a logic model. Whether this is applicable to the generally, I think it has some specific uses in terms of proof of concept and looking at spending a lot of time in terms of design, in terms of choosing the metrics. Financial modeling was an enormous challenge. Having our own management information system with real-time management so that we knew who was referring, what the link workers were doing, what the caseload was. There's a lot of work that needs to go into that, and to an extent, the CCG in effect outsourced all the commissioning, procurement, contract management to Ways to Wellness to recruit providers of link workers and to manage the providers of link workers and to take the risks of the whole contract. Now, I can't see that happening on a large scale, but I do think there are some real reasons why you need a lead provider model, and you need to think about a local area, because I think increasingly we need to look at place-based approaches. You need to look at a lead provider in a local area who will work collaboratively with the voluntary and community sector, and to an extent carry the risk of a contract, but also have subcontracts for delivery of activities with a whole range of local people. So I think all of this goes into, we need more detailed design of how this is going to work on a place-based basis and how it's going to make best use of existing local assets and to develop assets when those are missing, basically.
Thanks, Chris. Martin, I was wondering, did you want to come in on this issue of the funding models, because you've got more of an oversight from your NHS England role?
Yeah, obviously we've got to look at how we support social prescribing right across England. So my understanding of the social impact bond has enabled a particular piece of developmental work to happen in Newcastle. So we wouldn't be looking to kind of replicate that everywhere else. But I think I'd completely agree with the points that have been made that we need to help every local area look at how they design social prescribing in the context that actually find themselves, because it's going to be very different according to the demographics of the local area. So we can look at how best to invest the money. I think Chris's idea of a lead provider is definitely worth exploring, but the funding for the development of the link workers is already in place through primary care networks. The contract for GPs enables us to employ the link workers, but it's the other elements that you've been talking about that need the kind of thinking through and understanding how to finance.
Thanks so much, Martin. Okay, we've got some slightly more specific questions now on the presentations, and John, you're up first. There's a couple of questions on the quantitative analysis. So there's one from Leah Avery, which she says, excellent presentations, everyone, which is nice. The improvements in HbA1c were particularly encouraging. Do you have data on baseline levels for study participants? Because she wonders if the intervention worked better for those with better or worse glycemic control.
Yeah, thank you for the question. Just, I mean, I can, maybe it's best if actually I just deal with both of these here. So
yeah, great, if you can.
So Elaine, I think it is, has asked about the information and duration of type 2 diabetes. So if I just sort of deal with those. So we did start doing some work on dividing people by baseline HbA1c. However, because it's secondary data, and obviously we're getting this from QOF, you've got this issue of where people appear in the timeline. And of course, because HbA1c is an outcome, to stratify people by the outcome before you look at the treatment, to look at that, potentially can build in some problems of bias. So I know we started to look, but we stopped, but I can't remember exactly why we stopped, but I think it was something along those lines, and there were some concerns there. But it's certainly a very good point, and certainly something I've considered, and something like I will certainly reconsider now that you've raised it again. For the duration side of things, I'm afraid we didn't have any details about when the actual diagnosis of type 2 diabetes occurred. We only knew that they had a diagnosis of type 2 diabetes for the time that we observed them. So we were hindered in that back, and again, this goes back to the point about making sure we've got the right access to the data to look at this properly.
Thank you. Okay, we've got some series of questions now on the ethnographic work package. So if Tessa and colleagues feel free to chip in, and whoever wishes to answer. So one is about asking about, did link workers themselves have any comments about the drift towards more signposting work and how this might have impacted their capacity to reduce health inequalities more widely? And another sort of link questions from Amy O'Donnell, which is about, given that a lot of the clients also had anxiety and depression, was there any feedback again from link workers about this aspect of their role, and was substance abuse something that came up in that? So a couple of questions are probing a little bit more about what you found with the link workers.
Can you address that, Bethan?
Yeah, I'm happy to pick up on a few of those points. Perhaps in terms of the mental health aspect, it was very evident in the data that there was a significant mental health burden within the population that the link workers were serving. In terms of link workers' capacity to address this, there was training, and I saw there's another question about training, and we can touch on that. The training was quite differentiated, and it wasn't always consistent, and there was a temporal aspect that meant when link workers started, they maybe had to wait for training. So in terms of addressing mental health issues, it could be very difficult, compounded by the long waits within local services for access to treatment for mental health services. So often link workers found themselves in this position where they were almost sort of holding clients as they were waiting to access treatment for mental health, and obviously there were implications as a result of that. So there was one example in the data of a link worker who had a patient who was suicidal, and she was sort of trying to help manage that while he was waiting to access services, but he could contact her at sort of unusual times of the day, and so really taking on quite a lot of responsibility, and I think there are discussions to be had there about sort of implications of sort of safeguarding and so on in terms of training. There was training on substance misuse. There were no examples in the data that we observed of clients who were accessing treatment for substance misuse, but I think what was also clear within primary care that there were other services as well that these people could potentially access. So it may well be that they were had already been referred to another service that didn't involve the link workers. So I think that's covered briefly some of the points raised, but I'm happy to go into more detail if people want more detail in any particular aspect.
Thanks, Bethan. There's another question which is about was there much by way in terms of looking at the GP's perspective on social prescribing in term, you know, in the qualitative research that was conducted as part of this project?
Yeah, so there was very little in terms of observed interactions with primary care staff. There was one quote, which I think I included in the presentation, that acknowledged that it could be difficult for primary care staff. Alongside working on this project, I'm also conducting a PhD which involves doing an ethnography in primary care pre-COVID to look at this. And I think some of the issues from the primary care perspective that are emerging from that data are there is a significant need for an intervention like this. Clearly, there's a lot of unmet need in terms of a social intervention for health. But I think some of the issues were around other interventions and other roles that exist within primary care that people may be using, the complex landscape that's emerging around social prescribing and knowing who to refer to and which referral criteria apply to which role. And then the other thing I would say from a primary care perspective that perhaps brings in sort of some of Kate's data is the clients, from the link workers call them clients, obviously in primary care, the patients, those that are offered the intervention and decline. So there's something about positionality and being able to engage with the intervention, but clearly from the primary care data, it's becoming quite clear that there are several people who never actually make it as far as the link worker. So I think they're all things that in future will be interesting to explore.
Thank you. Stephanie Tierney and Karen Husk, I wondered, because you're obviously involved in leading other evaluations, other parts of the country, I wonder if you are able to also reflect on this question about what is the kind of how a GP is viewing social prescribing. Has that come up in some of your work? Oh, thanks, Stephanie.
Well, I'm happy to start and Karen can sort of come over, but I mean, we are starting data collection for this one project imminently, but in terms of our conversations with link workers, it seems as if there's sort of, it seems quite crude to say two broad camps, but this is how people, link workers we've talked to, describe it as the GPs who are very enthusiastic and have a sense of what it's about, and then the other end of the spectrum where they're not really sure what it's about, they can't see the value to them or to the patient. So often the link workers that I've spoken to anyway have talked about sort of GPs interaction in those two different sort of scales of, and I'm sure there is a continuum, but that's how it tends to get talked about with the link workers that we've talked to.
Thank you. Thanks, Stephanie. Karen.
Yeah, so I completely agree with all of that. And I think the evidence is a little bit lacking in this area, but it's useful to point out, I think, that from all the evidence that I've seen in GPs we've spoken to, that they need sufficient evidence to include social prescribing as a tool in the box, not to be completely convinced and become a champion, not to completely cast it out, but just to use these pathways as another tool in the box. And so the bit of the evidence that's missing, as far as I can see, is that decision-making process between GP and patient is a bit of a black box at the moment. And certainly there may be people who understand that, there's a little bit written about it, but getting that out into the social prescribing community about how those decisions are made, what essentially are the criteria. Chris is going to tell me I'm completely wrong now. But having better understanding about that decision-making interaction and making that black box a little bit more transparent for all of the people in the pathway, I think would be really useful, because then that means that all the information is getting across the pathway.
Thank you. And I think just to add to that, how we get feedback to the GPs once they've referred someone to the link worker is another thing that's come up in some of the evidence that I've read, but also just talking to link workers and having access to sort of online GP, electronic GP records. That's not always the case for some link workers. So there's a lot of sort of discussion about how do we let the GPs know when they've referred someone what the what's happened to that individual and how they've progressed or not, is something that I think would help with getting GP buy-in if they've sort of heard the patient journey once they'd referred the person to the link worker.
Thank you. Thanks both for coming in on that one. I got a question of my own, which is for John, I think, which is you were talking in the presentation about statistical significance and clinical significance. And at some points I could perhaps see where there was one and maybe not the other, and sometimes there was both. But I wondered, could you just say what you meant by that in the context of your findings, just so that it's clear for colleagues.
Yeah, of course. So statistical significance is based on that sense of how likely is your result to be a true result. So that's the sort of the criteria that social scientists often work by. Is it a statistically significant result? But then obviously the important second question is, but is it also a meaningful result? So what we were finding with in our intention to treat HbA1c results, for example, is that the change in HbA1c was small. It was not. So if you were considering a new intervention tackling HbA1c, I mean, another sort of metformin type of thing, and it was like, here's a prescription for it, we would expect to see HbA1c fall by a clinically significant amount, or we'd hope to see it fall by a clinically significant amount. Now, as I say, I don't really think that's necessarily the barrier that you should set for social prescribing, because whereas a prescription, whereas a drug aimed at tackling HbA1c, blood glucose control, that is its target and primary outcome. Social prescribing, that's not the case. So some of these results were small, but in certain subgroups we did have results that do seem to be clinically significant and that matter. But I think it's that point about, and when you're presenting these things quite quickly, and even in the report when it does come out, to put that nuance around everything is actually really quite difficult, and I think that's why it's useful to be able to explain that a little bit more.
And if that it was scaled up, then it could have quite big impacts potentially. Yeah, I mean, to see that across populations are bigger, and as I say, if over periods, I mean, I think I can't remember, I think it was Stephanie saying about over the periods of time, making sure we've got the periods of time right. Just again, you think about the nature of what's going on here. If you're trying to tackle the social determinants of health, to see a response in 3 months, 6 months, a year, these things should take time to manifest themselves. And so that's one of the reasons we liked it. We were pleased with the HbA1c results and the blood pressure to some degree, because you could see that gradient taking place. Thanks so much, John. And I've got, I think, maybe 1 or 2 questions. So this is my last call for any burning questions you might have to put in to the chat, please. And I've got one other question, which is about, there's a lot of sort of more specialist link worker roles being advertised, and colleague Emily Tupper would like to hear about what a more community targeted approach might look like. And I think there was talk, Chris was talking about, taking a more holistic place-based approach versus these more specialist roles. Chris, I wonder if you could come in on that. I think I've put 2 questions together there.
Okay, the more specialists, yeah, I mean, I'm involved in another project which is looking at link workers in primary schools, working with children who don't meet the threshold for a mental health or a special educational needs service, and clearly the skills and competencies required with that group of children in primary schools is very different from the skills and competencies required when you're looking at adults with long-term conditions. So I think if we're going to take a population health management approach, and we're going to be more targeted to particular communities of need, then we need to think about more specialist roles for link workers. In terms of a more holistic place-based approach, I think there's a whole number of issues here. I think there's an issue about where are we recruiting link workers from, and where are we providing the initial training? I mean, in terms of Ways to Wellness, because we've been operating now for a long time, graduates of the programme are now volunteering and working with some of our link workers. And in time, I suspect some of those will go on to be trained and become link workers themselves. So I think there's an issue in terms of almost job creation, particularly within disadvantaged communities, where this whole notion of support from next door is more important than advice from on high. So I think that's one element of a more holistic approach. I still think within that there is a need for some targeting and some specialist roles. So I wouldn't go to a totally generic general role. And equally, I also think there is a need to work very closely with general practices in those areas, because actually at the end of the day, general practices is where people go. That's the footprint for the local area, and they're very much, or should be very much, part of the local community. So working with those practices and bringing together local voluntary and community sector organisations and practices within primary care networks, I think is incredibly important.
Thanks so much, Chris. So there's no more questions. There's a lot of chat going on in the chat, which is also great, although slightly confusing for me. Yeah,
Claire, sorry to cut across you. Jane has got her hand up.
Oh, sorry, I didn't see. Jane,
to come in here.
Yeah, sorry, just to add to what Chris was saying, I think in terms of that sort of advice from next door rather than on high, recruiting from local communities, we have seen that where you have voluntary and community sector organisations hosting link workers, employing link workers, then they are perhaps better placed to recruit people from the local community, and also, if you like, create that environment and understanding that is required around community models, community development, which is perhaps sometimes there has been some evidence that within general practice, depending on the practice, on who is line managing them, that clinicians, sometimes their knowledge of those approaches is perhaps not as great as it could be, she says, trying to be very diplomatic. I think we also need to recognise that there is now some level 3 accredited social prescribing link worker training that is available, and here in the Northeast through our integrated care system we have funded 2 or 3 programs to support link workers, but there's also nothing like additional learning on the ground, being embedded in a voluntary and community sector organisation and learning from actually doing the job. So I think it's a combination of those things.
Thanks, Jane, and thanks, John, for acting as my eyes. And I see Martin as well. You see, you call last orders and then everyone wants to be at the bar. Go ahead, Martin. This might be the last word of the day.
Okay, thank you, Claire. It was just on the issue of how do we get GPs to know what's actually happening, who we're reaching and what support we're getting. We're going to be consulting on an information standard for social prescribing with a group called the PRSB. And if that comes off, what it will mean that information will go between the link worker and the GP and get included on the health record. Just really key stuff about who we've actually reached, what their needs were and what support was offered for them. And it'll also make it easier to record the kind of outcome and experience measures that the better schemes are already using. So we're hoping that will help with this problem that a lot of GPs don't actually see what goes on for the person, and the link workers don't have access equally to the primary care information systems.
Thanks so much, Martin. Okay, that's definitely it. I'm afraid the pub is closed, and I'm going to hand over to John, who's going to close the meeting. And just before, I just give my personal thanks to the presenters for a great job today, and also to the panelist discussants who've come on and given their time and their perspective. So thank you very much for that. John.
Sorry, I lost my mute button. Sorry, just got a few slides to finish off, so sort of acknowledgements. So first of all, I'd like to acknowledge the team would like to acknowledge the National Institute for Health Research for funding the project, and we're still in the process of putting the final project together. We would especially like to thank the study participants. I mean, especially I think I speak on behalf of those working in the qualitative work, that all the effort that they put in and their contribution has just made this, given us these invaluable results and a great experience, I think, for those people involved. So I think that's been absolutely tremendous. We would, of course, like to extend our thanks to Ways to Wellness, the provider organisations and link workers. I mean, Ways to Wellness, they've provided information. They've always been there. They've been involved in planning this from the very start. The provider organisations and the link workers, they've tolerated us, put up with us, accommodated us, and that's been absolutely tremendous. We'd like to thank it says the Newcastle Gateshead Clinical Commissioning Group, and again for their support throughout the whole process. And again, if them hosting Ways to Wellness has allowed us to undertake this research. We're keen to thank the North East Commissioning Service, as I mentioned Bob Gaffney, but there's also Rick McLeod, Azim Dinsdale, Billy Moyle, Sean Curry, all of whom were very, very helpful in getting this together. And I'd like to thank the research team members who have presented here today and contributed today. And I think hopefully you found it really interesting. But I'd also like to thank those who couldn't make it today. So Wael Mohammed, Owen Maloney, Jane Jeffries, Mark Pearce, Linda Penn, and Alison Lawson, who looked after us all and made sure we were all kept on the straight and narrow for the whole time. I would also very keen to say thank you here to the speakers who's presented. So I think it was a really good job, really interesting. I'd like to thank the panelists as well. I thought your brief was challenging, your timing was challenging, and the fact that you made so many insightful points in that period of time was absolutely tremendous. And we really, really thank you for your contribution. It's given us some more things to think about, and certainly, especially for my work, to go away and think further, and hopefully we can help to build this and get that evaluation of social prescribing really, really well done, and really benefit the service and the people who use it. I'd like to thank Claire. I know Claire was thrown into a chaotic situation on Saturday, and she has stepped in and, while juggling many balls, has managed to run this very smoothly and dealt with us all and kept us all in check. So I'm very, very grateful to Claire. Thank you. I'd like to thank the Fuse team. I mean, Cheryl and Laura obviously have been supporting us here, but the Fuse team helping us to put this together, advertising it, and making sure that we could share screens, which seems like it should be simple, but is always so difficult. And of course, I'd like to thank the audience, your chat, your contributions, and we hope you've really enjoyed it. It's been really, really great having the opportunity to speak to you. There's further information, so there's a couple of published papers. So there's one with Kate as the lead author in the Social Science and Medicine. There's one that's just come out in the JAMA network. They're both open access papers, so please, go and look at those. I said there was an earlier paper from the study which isn't listed here that was in the Value of Health that Joe and I wrote, which again talks a lot of those evaluation things. There's the study website, which is active still, so please do check that out, and do watch out for the reports. That's still going through the labyrinthine and bureaucratic process of trying to get it published by the NIHR, but that may happen. That may happen before we're all in lockdown again. It may not. Finally, I think here to advertise Fuse's next event. So on Thursday the 14th, the quarterly research meeting supporting smokers to quit. And maybe I'll leave that slide as there just for people to have a look. But most of all, once again, thank you to everybody, and thank you for your contribution.
Thanks, John. Thanks everyone for making today's event such a success. And I hope to see you at the next quarterly research meeting.